My name is Paul Nghiem. It's a great pleasure to chat with you briefly about a few of the exciting updates happening in Merkel cell carcinoma management. I think they're happening in multiple realms in terms of the interaction between surgery and radiation. There's a lot of progress in terms of how do we manage the initial tumor, and also, of course, in immune therapy. We all now are doing anti-PD-1 pathway blockade for managing advanced disease, but huge numbers of questions, including when do you stop that in Merkel cell carcinoma? The answer does not seem to be the same as for melanoma. And we can talk about that in a little more detail. And also, what do we do for refractory disease, which doesn't initially respond or becomes in an acquired way unresponsive to anti-PD-1? And then a third area that I think is very interesting and where there's, significant progress is, new trials coming out in the space of quote, upfront immunotherapy rather than just relying only on surgery and radiation, and when do you take that kind of approach? So lots of progress in Merkel cell carcinoma. It's really a different disease than the other skin cancers in several regards. So it's been an interesting last couple of years, and it's nice to be getting together, at least virtually, with some colleagues. There trials in Merkel cell carcinoma can be broken into multiple categories. There are several trials in Europe, the United States, and Australia exploring the adjuvant space, and none of them have really reported out yet. But we all suspect that adjuvant immunotherapy for high-risk Merkel will offer some benefit, but we just don't know how big that will be and what kind of regimen should be given for how long. So those trials, I think there are at least 6 that are ongoing, and we don't have, all I can say there is please try to enroll your patients in those trials so that we can get to answers more quickly. Because it's really not, I think it's not appropriate to just give adjuvant immunotherapy now off trial, and it's not covered in the United States, and I don't think it should be in the absence of data. And there's good availability of multiple trials. So that's that space. There's a neoadjuvant trial that was recently reported, and when you have a big, bulky, nasty local or regional Merkel, it is clearly an option to give upfront or neoadjuvant immunotherapy, and a little more than half of patients will have a very rapid, very deep, very clinically meaningful response. The trick is, in Merkel, it grows so fast, waiting about 4 or 6 weeks between starting an immunotherapy and assessing whether it's going to really work or not can be bad in terms of the tumor progressing and making it more difficult in the subset of patients that do not respond to manage with surgery or radiation. So that is, we continue to believe, a really hard topic to answer on an individual patient. You really have to think carefully, what's the right outcome? How do we manage it for each patient? Because the stakes are high. If you do have an early response, it is abundantly clear, and this is similar in melanoma in the neoadjuvant setting, it's abundantly clear that's very meaningful for control. And that gives the patient and you a lot of information as well. Then there are trials in the refractory setting, and those are fewer and farther between than we would like. Moffitt Cancer Center has led the largest, earliest, and most significant trial up to now, and that combines either Ipi-Nivo or Ipi-Nivo plus stereotactic body radiation randomized. So you're going to get Ipi-Nivo either way, but you may or may not get additional radiation. And those results are not officially out, but they are definitely seeing good results in both groups. I think it's clear that radiation does not add magic to that mixture. It can be very helpful in managing some tricky lesions, but Ipi-Nivo will help about 20 to 30% of patients who have refractory disease. Of course, at some toxicity cost, but there are two papers, one from Europe, one from the United States, showing that ipi-nivo can, in a moderate fraction of patients, help them. So I think that's the standard by which we will be comparing future trials in this refractory space.